Welcome to Brain Ponderings, your window into neuroscience research, conversations with experts in their particular area. And today it's my great pleasure to welcome Dr. Josh Helman. He's he's focused, I guess, the last part of his career and probably the rest of his life on lifestyle medicine, and particularly applying lifestyle medicine principles and science to brain aging and with the goal of reducing one's chances of developing dementia and perhaps even uh, improving the lives of those with dementia. Although there's no drugs yet that have any meaningful, hardly at all effect in Alzheimer's patients, there may be some other approaches that can be beneficial. So welcome, Josh.
Thanks, Dr. Mark. And actually, yeah, no, it's been exciting because I think I've found a drug that is helping with many
Oh,
of my Alzheimer's patients, and we can get into that.
okay.
Thank you for the warm introduction. It's great to be here.
Okay, so why don't you talk about your background because your training earlier was in biochemistry.
Yeah, sure. So I have two degrees in biochemistry, and but just to be upfront, I was a nerd as a teenager. I was studying biochemistry textbooks when I was 17. Yeah. So it was an early love, and I got an undergraduate degree in biochemistry at Harvard. I actually did some research on the with Howard Berg on chemotaxis and the motor that E. coli uses
Huh.
to get around and how that signals. And then I ended up also doing a biochemistry degree in England at University of Cambridge, specifically looking at contrast agents for surgical clips,
Huh.
uh, for MRI type things.
Oh, interesting. And then you, so you're board certified, I guess, in two areas. One's emergency medicine, and the other is well, lifestyle medicine.
True. Yeah, yeah. Yeah, and that was an interesting transition because I finished medical school and didn't know what I wanted to do. Started off actually in surgery of all things, and I
Okay.
found I really enjoyed the quick cases in the emergency room. So I transitioned to emergency room and actually I feel like I had a great career, over 20 years traveling all around the country,
Huh.
licensed in 14 states and it was really exciting working in the emergency room. But a dozen years ago, I found that for my own health, I was 50 pounds overweight, had high blood pressure, and I couldn't fix myself despite having all this training. It was just so humbling. High blood pressure. I'm taking blood pressure medications are not working, and that's when I was like, wow, I've got to take a step back and start looking for other options, other alternatives, and that's where I found lifestyle medicine.
I see. And what's your current positions then? Do you have more than one position?
I do. So I feel like I have about four different hats that I wear. I actually, number one, I'm the chief medical officer at Hippocrates, which is a raw vegan retreat focused on specifically lifestyle, what people are eating and getting them to exercise and to reduce their stress and get them to sleep properly. And then I'm involved with two different startups in the Alzheimer's space, reversing Alzheimer's in people. One is called Brain Power Clinics
Huh.
com, and the other is Alzheimer's Treatment Centers of America.com, ATCA.ai. And with both of these, the goal is to actually take these theories and in real world try to reverse and prevent Alzheimer's, which is why I know about this FDA drug for compassionate use. We're actually seeing good results so far in our hands. And then the fourth hat that I'm wearing is frankly why I'm with you today is trying to get the word out to as many people as possible that Alzheimer's is potentially preventable and reversible, that there is hope, that unlike what a lot of people hear, and that there's absolutely no hope and there's nothing you can do, that there's so many different treatments in the pipeline, and that there is hope, and that people should be proactive, be to help their own health.
Yeah, so you said your own personal experience was you were overweight, had high blood pressure, and you were that's in a danger zone for developing dementia when you get old, whether certainly vascular problems, cerebral vascular problems, but there's pretty good evidence that I call it metabolic morbidity, um, overweight, not getting any exercise, maybe some insulin resistance, and so on. And before we get into the pharmacological approach, let's talk a little bit about what the epidemiological and preclinical, and then even some clinical data, for example, in patients with mild cognitive impairment, say about uh, reducing one's risk and improving one's cognition. Do you want to, I mean, why don't you take the lead on this? This is
Sure,
your
certainly.
show today.
Okay. I appreciate that. Yeah, so no question that there's a huge risk being, as you mentioned, overweight, having insulin resistance. And I was definitely on that pathway. And I also had a family history. My grandmother, Eileen, had Alzheimer's. So I saw it as a teenager firsthand, this. And that's what motivated me to switch to that field. But specifically talking about brain function and Alzheimer's, type 2 diabetes with Alzheimer's has also been called type 3 diabetes because one, and it's just one of the root causes, turns out to be insulin resistance and elevated glucose. And I say one because we now know that literally there are between 30 and 200 root causes of each case of Alzheimer's. So I wish this was simple. It's just metabolic. It's just if you can reverse diabetes or lower your blood sugar and insulin resistance, that all of a sudden, boom, you're not going to get Alzheimer's or other brain disorders. Unfortunately, that's not true, but it is, as you mentioned, a huge risk factor. We know epidemiologically that the there's definitely an association, and but there's also association. You mentioned being overweight. Our society, unfortunately, in the last many decades, it's become an epidemic. Where now these days, two-thirds of Americans are either overweight or obese. And you're exactly right. I would have become, I think, in that pathway if I had just said stop and let me figure out what I can do to fix this. And sure, I definitely had stressors. Working in emergency rooms, working night shifts. We know that's definitely a stressor and will can lead to insulin resistance, etc. And of course, the foods available nor in most hospitals I worked in were not health promoting, and there's so many levels to it, but it's amazing how Alzheimer's at its root core, one of the causes is definitely metabolic and insulin resistance.
And of course, advancing age is the major risk factor. For the most part, unless there's a genetic cause with specific gene mutation, people don't get Alzheimer's till they're in at least their 60s, but it's much more common in the 80s, late
It,
70s and 80s. So there's quite a bit known at the, biochemical level about um, some typical changes that occur, and seems like throughout the body and brain with aging, oxidative damage, accumulation of dysfunctional proteins and organelles, inflammation, and and others. So, um, and getting to the causes, I mean, it's a multifactorial thing. I don't think we can say there's one cause, but something happens, and then you get a cascade of events that kind of cross amplify each other.
Exactly. And normally it's not just one thing. So just to be specific, we're not just talking metabolic, we're also talking about head trauma can contribute, so can toxins, infections. There are just so many that and when they come together, they often lead to inflammation. You'll see amyloid deposition, tau tangles in the brain. And what's also really interesting from the demographics is that it often takes 30 years for Alzheimer's to develop, but people may not be aware of the the problems with their brain
Yeah.
till 20 years in. And it's fascinating to me that the brain just has such excess reserve that you can destroy so much of it and it can still work until the very end. Almost like the liver, where you can destroy 90% of the liver but it can regenerate and come back.
Yeah, I think a lot of that is that most people in their daily lives and occupations, their brain is not pushed to its limits. Its capabilities are much more than we use on a daily basis. And so, um, I think it's likely there's some deficits that show up earlier that if you had developed certain kind of cognitive challenges that were particularly demanding, uh, it might show up. Yeah.
Right, a kind of a stress test. And
Yeah. Yeah.
and speaking of stress, I think people these days in modern societies, in some ways, there's a lot more stress than our ancestors had. Not always, but in terms of some of this technology where many people are checking their phone almost 24/7. Guess what? When the sun sets, our ancestors, most of them would go to sleep because there really wasn't a lot else to do.
Yeah.
Whereas now, we can keep the lights on 24 hours and uh and speaking of sleep, what the studies are showing is that not enough deep sleep is the number one risk factor for developing Alzheimer's. Specifically, you need the deep N3 sleep where the brain is able to clear out the amyloid and consolidate memories.
And that's usually the first couple hours of sleep.
Correct. You can get into it relatively quickly. What's interesting is that, when we were in our 20s, we probably had a couple hours of N3 deep sleep. But by the time we reach, say, age 65, we're normally down to like only 30 minutes of this
Oh,
deep
wow.
sleep. So it's yeah, so it's profound the importance of sleep, and I certainly wasn't taught that in med school. I was taught, be resilient. You don't need sleep in the hospital. You just, work 36-hour shifts and just be strong. And we now know that that's ludicrous if you
Yeah.
want a good functioning brain.
Yeah, I've had over the few years I've been doing this podcast, of course, I've had a number of people who work on Alzheimer's related things. Ron Peterson from the Mayo Clinic, a lot of work on mild cognitive impairment, but also at the basic cell molecular level. And so with sleep, the our brain, when you record an electroencephalogram, what you have is these oscillations in different frequencies. And Li Wei Sai I had on, she's at MIT, and in mouse model Alzheimer's disease, she found if she exposes the mice to a gamma frequency um, oscillations, that it had beneficial effects. And I think they're trying to, I don't know if you're familiar with that, but that's something that seemed because you can do it with apparently with light too.
Sure, it's
Yeah.
basic entrainment from biophysics,
Yeah. Yeah.
and you're doing that with the brain. So I'm not specifically familiar with her work,
Yeah.
but the concept, yes. I mean, some of the devices we're using uses frequency in order to facilitate sleep.
Ah, right. So you do that in the clinic.
Correct.
Yeah, okay. Interesting. And so you and how are you applying? Is it it's not light. I mean, you don't you have electrodes?
Actually, some of it is. You can use red light therapy.
Ah,
So that's one way. Another way we're helping with the deep N3 sleep is there's a device where we're stimulating four areas of the spine in order to increase production of melatonin and increase the vagus nerve firing, which leads to an increase of this deep N3 sleep by 44%. So
interesting.
that's really exciting, given that not enough deep sleep is such a risk factor.
Yeah. I had Kevin Tracy on talking about, vagal nerve stimulation and how it affects the immune system. It's pretty interesting stuff. Uh, yeah, so these are all, so talk about why don't you give, so someone comes into the clinic, lifestyle medicine clinic, and their goal is to reduce their risk for Alzheimer's. So kind of give me a typical, how long are they in and how many different kinds of approaches to change their lifestyle, modify their lifestyle do you work with them on?
Sure. So normally people are there between 1 and 3 weeks, and the focus is traditional lifestyle. So number one, what they're eating, try to get them away from processed foods, get them away from added salt, oil, and sugar, and having them eat more whole fruits, vegetables, and whole grains. So there's the diet approach, and then there's sleep, making sure they're you know potentially getting a sleep study and making sure that they're getting enough of this deep N3 sleep. Next is exercise, because as you know, exercise stimulates the release of BDNF, which then leads to more neurons and synaptic connections. And then the next thing we'll focus on is reducing stress. And there are many ways to do that, whether it's yoga or breath work. And the other cool thing is if you get someone at a resort away from all the interruptions, often just that will reduce their stress if they're not constantly
Yeah.
checking the TV or their phone or devices. And but of course the flip side is when they leave, if they go back into that world, you have to give them tools to use to decrease their stress. And then another important thing on the lifestyle is community, making sure they have support, someone that can help them make this journey easier, whether it's another family member or friends or neighbors or even online connections. So that's the first thing I would do is focus on lifestyle. But often it's not just lifestyle because um, many people have medical issues, and
Yeah.
one of the tests I like doing is testing their cognitive ability, their memory, their processing speed. Typically, we'll use a computer test that might take up to an hour as an objective measure of how people are doing, and then we can repeat that test once a month and make sure that whatever interventions we're trying are actually working.
Yeah, and this is good. This raises, we have a lousy healthcare system in this country. It lets people get sick and then gives them a drug. And they, for drug addiction, they have rehab, right?
Right.
And so I think, with someone with obesity that just can't, improve their lifestyle, I think there should be insurance should pay for like 1 month of rehab uh, to get people to change, and then I mean you'd have to do the study and get the data, but I think quite a few people would come out at the end of a month and be able to incorporate long term, ch those at least some of those changes.
Dr. Mark, I agree with you 100%. Our current system is backwards. We focus most of our energy, time, money once someone has advanced chronic diseases, and there's almost no attention or resources put on preventing. And as you know, it's a lot easier to prevent most of these conditions than to try to reverse them once they're there. So I agree with you 100%. We should be insurance should be paying for, say, a month of lifestyle intervention before, say, doing a surgery, removing some of their stomach or other invasive procedures that are risky. And what's scary is once someone has uh, these bariatric procedures, often they can no longer absorb nutrients as well. If they ever convert to eating lots of plants, so it's a
Uh,
catch-22, and that's why I'm glad that we're talking about this because this is really important. And the what I tell people is just because insurance doesn't pay for something doesn't mean it's not in your best interest. And you have to put yourself first. The same is true with the whole reversing biological age field, that right now insurance won't pay for most of those things, but the cool thing is if we can lower your biologic age, you're not going to get these chronic conditions most likely.
yeah. Um, uh, yeah. So I had a couple podcasts where I just essentially gave lectures on the problem with the food industry, problems with the food industry, and the problems with pharmaceutical industries that they're both for profit. You got big agriculture with monoculture, growing corn sprayed with herbicides and pesticides, and then you make high fructose corn syrup out of it and put it in drinks, and then the a lot of the senator our representatives, senators and congressmen are lobbied by big agra or pharma, and it's a big problem. Uh, Somehow you got to get the people in power on board to make changes. Don't subsidize big agriculture, promote smaller organic farms and then figure out a way to get these healthy foods to people in the inner city who, particularly poor people who, they they eat bad food. It's high calorie density and not a lot of good things in it.
I agree 100%. Yeah, let's promote people growing their own sprouts at home. I mean, there are things people can do. It's just you're exactly right. Industry has captured a lot of politicians, and for long-term health of our country and our people, we need to start, take things back, take the narrative back, take the food pyramid back,
Yeah.
and let's focus on long-term health and well-being.
Yeah. Okay. What about fasting?
I'm first of all, I love, I'm a big fan of fasting. I'm a big fan of yours. And I definitely encourage many of my patients with brain conditions to fast. Obviously, if someone is super skinny and they have no excess fat, I can't do a water fast on someone like that.
Yeah.
But so you have to personalize it, you have to individualize it. But in general, even for almost everyone, I can say, you know what? Don't eat 3 hours before you go to sleep.
Yeah.
I can say potentially skip breakfast, and unless they're a brittle diabetic or something like that. So for most people, I can get them to intermittent fast with,
Yeah.
maybe a wide window and maybe narrow it at times, and I can follow
Yeah.
their hemoglobin A1C and or a continuous glucose monitor just to see how they're doing.
And do you see beneficial effects?
100% I do.
Yeah.
And and I know it's controversial in the Alzheimer's research field, at least with people, is there's some Alzheimer's doctors who are advocating for a ketogenic diet, and then there are others who are focused more on, eat lots of plants, and I would say I think both are beneficial, and I also think it's flexibility, being flexible, whether it's carbohydrates or fats, being able to metabolize both.
Yeah. All right. So go ahead and start talking about, what you're doing with patients that already have dementia, either mild cognitive impairment or probable Alzheimer's. When the diagnosis of Alzheimer's is made, it's actually probable Alzheimer's because until autopsy, you can't really say that the brain, there's enough amyloid accumulation and enough tau neurofibrillary tangles to meet the criteria. Although it's like it's a spectrum. When you look at pathology, my father had dementia. He was actually diagnosed by Ron Peterson at the Mayo Clinic.
Oh, wow. Okay.
Yeah, I'm from Rochester, Minnesota, so he's right there. And so he was diagnosed with probable dementia when he was in his early 80s, and he progressed, particularly and they did MRI and his structural MRI, and the thing that was striking was his hippocampus got progressively smaller over the next 9 years that he lived. And then, but when they looked at his brain at autopsy, it didn't really meet the criteria for Alzheimer's, but there was pathologies that have been typically linked with, for example, ALS.
Right.
It's called so-called TDP-43. And so the final diagnosis was mixed dementia, or could have been called hippocampal sclerosis of aging,
Okay.
which is another designation where there's a lot of massive loss of the hippocampal neurons, so you can't make new, remember anything new.
Yeah. So sorry you went through that. When I see patients on intake, I find, first of all, that they've had huge variation from workup from almost absolutely none to they might come with a whole book of their medical records. But to speak to the diagnosis, you're exactly right. Decades ago, Alzheimer's was diagnosed on autopsy, which isn't particularly helpful when people are still alive. But the exciting thing is we have now all these new tests and that can suggest it. So, for
Yeah.
example, you've got blood tests for p-tau 217, you've got PET scan for amyloid, and and what I think, though, is because this is such a heterogeneous disease in terms of root causes, where there are between 30 and 200 root causes, I think we're going to end up finding many of these cases are mixed
Yeah.
because it's just so complicated. But what normally I would do for a patient like that would be to make sure that they've actually had some type of brain imaging, a CAT scan or MRI, because often, and to me, it's kind of scary. People will start trying to get treatments, and the reason you want an initial brain scan is you want to make sure you don't have a mass in your brain
Uh,
or a bleed or something that's easily or potentially treatable.
yeah.
And sure, I'm a big fan of lifestyle, but lifestyle is not normally not going to fix a bleed in your brain, and that's why I encourage people to get a brain scan, either a CAT scan or MRI, if they've had no imaging. But assuming that we go through that, I will go through traditional testing, but I also, because I've seen so many cases where toxins are involved, I will normally push them to get testing for heavy metals and
Mm.
forever chemicals and pesticides and mold toxins and other industrial petroleum type toxins to see if that's an issue. And if it is, and in many cases it is, they have high levels of these toxins, I will actually suggest that we filter and lower these toxin levels with something called total plasma exchange, where we take blood out of one arm and get rid of the plasma that has all these toxins, and then the other arm, the blood will flow and will add back in albumin protein in order to keep the volumes comparable.
Huh. Yeah, the forever chemicals is kind of scary, right? Because we all undoubtedly have them in our brains, apparently.
Yes,
And
and plastics. And what's really concerning is these levels are going up and up and up.
yeah,
As unfortunately, we're still making lots of plastics and these chemicals in factories, and they go someplace, especially forever chemicals, they don't normally get degraded, and they end up in the food chain, and then they end up in us.
yeah.
And it's really it's scary, and this is why what I'm seeing is that the dementias of today, in terms of root causes, are going to be different than even 30 or 40 years ago because there are just so many toxins around. And here's another example: the with COVID-19, we're seeing huge amounts of these spike proteins that are doing damage to the brain too. So you've got all these layers of brain damage that our brains did not evolve to deal with normally, and so that's what I'm focused on, is trying to identify what are the problems. If it's toxins, it's going to be filtering the blood. If it turns out to be infections, we'll treat with antibiotics. If one thing I'll also say is that one of the root causes of Alzheimer's turns out to be inflammation, and the new FDA approved drug for compassionate use I mentioned at the very beginning, the way that works is it decreases the amount of galectin 3 protein in the brain. Galectin 3 is part of the immune system, it's part of the inflammatory system, and unfortunately, the levels are normally high in chronic conditions, including Alzheimer's. So, if you can get those levels lower with an antibody against galectin 3,
Um,
the amyloid plaques can dissolve, and inflammation in general in the brain can go down. And it's normally given intravenously once a month for 6 months, but I'm often seeing improvement after just one dose.
wow.
So that's why I corrected you at the beginning. It's like
Yeah.
in my world, like no, there are actually a ton of things you can do. And the exciting thing is when I layer all these different changes for patients, that's when I see the most dramatic improvements. Because if all I do is lower their inflammation with this galectin 3 drug, and I don't improve their inflammation from lifestyle, and I don't improve their diet, then guess what? They, instead of being on this for 6 months, they might need to be on this forever. And yeah.
Right. So what's the status of randomized placebo-controlled clinical trials of galectin-3, galectin antibody?
Sure. So they, um, I mean, right now it's they started with animal studies
Hmm.
where we're in phase 2B, and so we haven't yet gone to phase 3. So it's not a fully approved drug, but because we're seeing such dramatic improvement, and we're literally seeing zero side effects, no serious side effects, as opposed to, as you might know, some of the drugs out there with antibodies to amyloid, we're seeing in a third of the patients brain bleeds and brain swelling, but we're literally seeing zero. So, um,
And
uh,
and so those phase. So that those are blinded, right?
Um, it, so yes, those are blinded, but obviously as part of the expanded access program, compassionate use, they're not blinded. I'm not giving placebo
Right.
to patients. I'm saying, look, I want to offer you this therapy,
I see.
and it's not fully FDA approved, but here are the risks and the benefits.
Okay. And then do you do the cognitive, like battery of cognitive tests? Yeah.
I do, and the ones that I like are normally computerized, and I use a company called CNS Vital Signs. It's it's almost an hour long, and it's the Stroop test, and trying to remember 15 objects and then 15 shapes, and can you remember that
Yeah.
after a couple minutes, and then can you remember that after 50 minutes, and yeah.
And so the galectin antibody was developed for some other indication, right? Is it used clinically? It must be, or there wouldn't be anybody making it. Is it used for
Right.
another disease?
So what's exciting is it's being researched for Parkinson's and other conditions, but I'm not aware of any approval for this antibody yet.
Huh.
But fast forward, 10 years from now, I think we're going to be using it because we now know that galectin 3 is elevated in all these different chronic conditions from asthma to zoster to interstitial lung disease. It was actually the galectin 3 blood test was first approved in the United States by the FDA for looking at congestive heart failure for heart failure.
Huh.
So,
That's it.
but it's not being currently used for that purpose. We may see it used for certain types of cancers, but again, I'm not involved with that. I'm specifically focused on how can we use this molecule to decrease inflammation in the brain for Alzheimer's. But we're allowed by the FDA to use it in this country specifically for dementia. So if I have a patient with Parkinson's who also has dementia, as part of the
I
expanded access, I'm allowed to give it for that. But if it's just pure Parkinson's motor without dementia, I'm not allowed in this country yet. But I think that's going to be allowed very soon.
And then it's, a lot of times the antibodies are pretty expensive. Is it expensive?
Unfortunately, it is. I mean, we're talking up to say $10,000 a dose, and someone might need 6 doses. Similarly, I talked about total plasma exchange. That someone might need 6 filtrations, and each of those might be $10,000
Wow.
a filter. The good news, though, is as these technologies become more common, I think we're going to start to see prices come down. Yeah.
Yeah, and yeah, hopefully we'll get approval and then insurance will cover it because as it sits now, it's mainly for wealthy people, unfortunately.
Wealthy people, but also, and I see this scenario not infrequently, is people have um, you know, what capital in their home, or they may not be multimillionaires, but they have resources.
I see.
To my mind, if you're 70 in your 70s and your brain's not working, I mean, I would want to spend my resources to try to get my brain back because, like, what other upside do you have? And
Yeah.
that's striking.
Okay, so what else would you like to talk about
Wow.
that we haven't
Yeah.
covered so far?
Yeah. So, well, I'd like to review with when it comes to Alzheimer's that number one, there is hope,
Yeah.
um, because I'm seeing improvement. The other thing I'd like to talk about is what I'm seeing with infections. That infections seem to be linked to many, not all, but many of these cases of brain disorders. For example, there's a pathology study finding the Lyme spirochete in Lewy bodies that we'll see in Lewy body dementia. I'm seeing, and there's definitely an association with a infection P. gingivalis.
Huh.
in the
Yeah.
mouth with much higher rates with Alzheimer's. And I think the reality is, just like there's a gut microbiome, I think we're going to find that there's a brain microbiome that we uh, need to fix.
Yeah, and the nose could be a major entry point. You mentioned COVID, right? These respiratory viruses, things get up your the the blood-brain barrier between the nasal cavity and the brain is kind of, I would say, weaker than, and that's why, for example, there's some work going on with intranasal insulin administration for people with Alzheimer's. And so insulin's a protein, right?
Sure.
And but it can get into the brain when you give it intranasally, not so much when you give it intravenously. So the point is these viruses and maybe other pathogens that might be an entry point. And the gingivitis, your mouth and your nose are, at least mine are. My nose last night it was stuffed up a lot. I've got a
Oh,
cold, but
sorry.
yeah. So I guess there are times if you couldn't breathe through your mouth or through your nose, through your mouth, you'd be in big trouble when your nose is all clogged up.
That's true. And a couple comments. Number one, we're also seeing, for whatever reason, plastics, microplastics. The one of the preferred entry routes to the brain turns out to be through the nose, through the olfactory
Uh,
nerve, and we don't know why, but it seems like that's one of the pathways. Number two, most of my patients with dementia have a leaky blood-brain barrier and a leaky gut for that matter too. So
hmm.
it's a huge problem, but it makes sense if toxins, infections can get into the brain, that it can unfortunately speed along dementia. So yeah,
Yeah, yeah. Okay, so there's so many things that can go wrong, and it seems the average age of onset of dementia should be getting earlier, right? We're being exposed to these plastics and potential other, pathogens, and you'd think then that would shift so that more and more people would be diagnosed or develop dementia at an earlier age than the typical, like my father, I mentioned, early 80s. That's
right.
fairly typical for starting to have signs of dementia.
Yeah, and I don't have a study on it, but I'm starting to see more cases of people in their early 50s than I used to.
Yeah, yeah, and that's quite early.
Yeah.
Now, a lot of the people that come to your clinics are then they are overweight and they come in with a poor general health to begin with.
100%. Yeah,
Yeah.
they come in with other medical issues, and that's why this whole approach has to be personalized. There's no one pill that's going to fix everything. You need a physician to sit down with you and actually go through everything, make it personalized.
Yeah.
And one thing that I found extremely powerful is genetics, genetic testing, personalized genetics, where finding out what are the specific 20 gene mutations affecting your specific brain metabolism, amyloid metabolism, tau metabolism, etc. And then the exciting thing is, for each unique mutation or SNP, there are specific interventions, whether it's supplements or medications, that we can use, and we're seeing good results with this personalized approach. And this is really exciting because, decades ago in medical school, we talked about, oh, yes, someday we'll have personalized medicine. My point is that day is here. Now, unfortunately, I can't get insurance to pay for some of this advanced genetics yet, but I think it's money well spent if it can help me prevent or reverse disease.
Yeah, I have my own personal story then about, genetics. And so I developed this peripheral neuropathy thing beginning, or I would call it like a pain syndrome. So right now I'm sitting on a couple cushions and a donut cushion. This is just one example. So for decades, I've had a lot of pain, just the pressure of sitting down, particularly on hard surface. And then I used to run um, a lot every day, like probably average 6 miles a day. When I was at University of Kentucky, we lived 3 miles from the lab. I'd run in and back every day. And so I went to a friend of mine who's a neurologist at Johns Hopkins. I met Hoke, who we helped him out on some of his studies, did some electrophysiology and mice, but he's a peripheral nervous system guy. And and I'd gone to a lot of doctors for this stuff and did imaging and I couldn't figure out what's going on. Finally, he diagnosed me with a kind of an odd form that seemed to be a small fiber neuropathy.
Hmm.
Okay. And then in 2019, I had a mountain bike accident
Oh,
right after I retired. And I had to have three surgeries on my groin area. My
hmm.
adductors were torn, and then that really screwed up my walking gait, and I got tendonitis. And so anyway, I got this pain thing. So we did genome-wide exome sequencing on my DNA, and it turns out I have a missense mutation, so a one amino acid difference in a sodium channel,
Hmm.
voltage-dependent sodium channel that's highly expressed in nociceptive neurons, the neurons that
Hmm.
convey pain. And the mutation that there's a world's expert on these very rare mutations.
Okay.
His name's Steve Waxman at Yale. He's an MD. And him and then other places throughout the world have identified patients with similar uh, gain of function mutations where you have hypersensitivity to
Hmm.
pain. So what I have is called primary erythromelalgia.
Okay.
And so then Steve Waxman, he since he has ability in his lab, he uh, did mutagenesis on the gene. He made my mutation,
Okay.
and he expressed my mutated gene in cultured dorsal root ganglion neurons, the
Wow.
neurons, and recorded from them. And sure enough, but it's a strange thing because sodium channel blockers don't seem to help. This
Hmm.
particular mutation, the sodium channel blockers don't seem to work. So the best things I've found, I do take uh, a, a serotonin norepinephrine reuptake inhibitor, which seems to help. But then the best thing for me, interestingly, is exercise.
Wow. Okay.
And when I'm able to exercise, and I have these flare-ups, so right now I'm just doing stationary bike, not much else. But I think that anybody knows this. In the hours after you exercise, like you feel really good,
Oh yeah.
and my pain levels go way down. So then, but anyway, I just yeah, I think that getting genome-wide exome sequencing, you mentioned $10,000 a shot for this galectin-3 antibody,
Right.
but um, it's yeah, it's less than that for genome-wide exome sequencing. It's getting cheaper and cheaper.
Oh yeah.
And then, if we wouldn't have done that, I'd still be running around, doctors thinking I'm crazy, that you're saying you have all this pain,
It's
but
it's it's all in your head. What are you
right,
talking
it's
about?
all in your head. And
Oh,
so I think it's a really good idea. And my mutation, it was apparently a de novo mutation. That is, my father and mother didn't have it.
oh
So
wow.
I have some ideas of why I have the mutation. My mother was smoking when
Okay.
she was pregnant, and that can increase risk for mutations. So maybe there's something that, yeah, so I would encourage people to, if they have some medical issue and it's not completely clear, why they have it, um, particularly a chronic condition, to get genome-wide exome sequencing. Something may come up and may maybe make a big difference in your treatment.
Yeah, and one of the pearls I've learned in the genetics field is that it turns out that if you have a very rare mutation, often those are the ones most impactful.
Oh
And
yeah, yeah,
and I'm glad that you found something that at least exercise helps, deal with it. I sure hope you can find some other things too.
yeah.
And what I'm so excited is the advancements that are being made in this field. That I mean, who knows? Maybe in 5 or 10 years, you'll have a specific
There's a lot of work.
molecule.
There's whole
Yes.
companies.
Yeah.
Actually, this led to a whole the identifying of these mutations and the sodium channels responsible for the pain syndrome. That led to several companies in the United States, Japan, because opioid addiction, right?
Right.
So what if you can, in theory, these drugs should also reduce pain, not just in me, but in you.
Right.
And there's some recent clinical trials showing promise there. So it did, you know, and there's a Dr. Hoke at Hopkins, they're, they're a medicinal chemist at Hopkins who's he's still trying to get the high throughput screen. He's got my mutant gene and
Okay.
expressing it in screening drugs to try to identify some that are effective. So maybe down the road, even if not in my lifetime, this me getting the genome-wide exome sequencing may somehow help. And of course, I'm a scientist, and I most people wouldn't have known what to do
Right.
with it and so on. But uh, yeah, that's a good point.
It's real. I'm really optimistic about all these fields because with AI, being able to analyze specific, not just genes, but outcomes and crunch all this data, that we're starting to see patterns that, would not have come out otherwise.
Yeah, absolutely. Well, Josh, let's see. Yeah, this has been great. If there's any links you would like me to put in the description section to the podcast so
Okay.
that people can get more information, just shoot them to my email and then I'll put them there.
Okay.
But you're easy to find, Dr. Josh Helman, on the internet.
Yeah.
Although,
The
my,
easy.
my email
Yeah.
is, I don't know if your email is available on the internet because you're more famous than me or more
Aw, no,
popular. But
no, no, no.
I got mine up there. My Hopkins website has my email. I actually still communicate a lot by email. I never got on social media at all. I thought it'd be a
Really?
waste
Okay.
of time and cause a lot of trouble, and it has.
Yeah, so the easiest place for people to find me is drjosh.com, drjosh.com.
Okay. All right. Good. And what's in your future plans? What's you mentioned the galectin-3 antibody, and are there any kind of new initiatives on the horizon?
100%. So there are some peptides that are becoming available that hopefully I'll get my hands on in about 6 months. What other things? There when I go to conferences, there are about 80 new treatments in the pipeline. So the exciting thing is now that I'm out there, companies are actually coming to me to say, do you mind trying this new Alzheimer's treatment on patients as
Huh.
a collaborator. I'm really excited by some of the new technologies. I can't talk about it right this second, but yeah, I'm it's Yeah,
And, it,
I'm
and,
I'm very optimistic.
and I think there's still some potential for repurposed drugs too, very old drugs. I'll give you one example. When I was at University of Kentucky, we were doing a lot of work well, initially in cell culture, looking at things that protected neurons against aggregating amyloid peptide toxicity, and which actually one of the things we found, which I think is very important, is that the amyloid beta peptide renders neurons vulnerable to excitotoxicity.
Hmm.
And patients with Alzheimer's have increased incidence of seizures. And if you record EEGs, often, even if they don't have seizures, they'll have hyperexcitability. But anyway, there's a drug called diazoxide, which was used for hypertension.
Right, I remember.
Yeah, but and it's very potent
Oh
in
yeah.
lowering it almost to a dangerous extent, and so it's not used much anymore. There's better drugs, but it acts by activating potassium channels, which quiet cells. And but interestingly, there's these potassium channels in the mitochondria too that it activates. Anyway, so we found it protected neurons against amyloid and excitotoxicity, and we contacted the company that initially developed it I think they're in Florida. I can't even remember the company's name, and said, oh, and then a neurologist at Hopkins just kind of on a whim, I talked to him, and he gave diazoxide low dose
Okay.
that doesn't cause really any major effect on blood pressure at all. Uh, uh, he and this is anecdotal, right? It's just
Sure.
he claimed that some of the patients were improving, so we wanted to do a clinical trial, and they they weren't making it in large amounts anymore, and they
Okay.
said they're not interested
Mm.
in uh, making more. So that's just one example of something that's already out there that could potentially have a benefit
Repurposed. Yeah.
that there seems to be no interest. This is one thing, my pet peeve with a pharmaceutical company.
Yeah.
When something goes off patent, right? Uh, and so it's generic, and then the company doesn't make it. Then what the drug company does is they tweak the initial molecule by adding one OH group or whatever, just a minor
Yeah.
modification,
Make it different, a little bit different.
a little bit different, and then they do a clinical trial and they compare the new drug to placebo, and they don't compare it to the old drug, right?
Right.
And it's beneficial, and then the clinical trial is positive, and then they put a lot of money into marketing, and they go to the doctor's offices. I don't know if you ever get pharmaceutical company representatives, or when you were, I don't know if you're sitting down,
Yeah.
but maybe previously. And
Historically, no question. Yes.
yeah, and you go in a doctor's office and there'll be
Right.
a say it's I don't know, a surgeon, right? You go in their office and they'll have a plastic model of some body part, where the surgery is going to be done. And on the bottom of the model, it'll say Merck or,
Right.
right, so they give
Right.
them, they
Oh
give,
yeah, oh yeah. No, I remember like for example when Viagra first came out, the Pfizer reps were giving out Viagra pens, and they were
yeah.
actually valuable. People wanted them, but the connection here with Alzheimer's is there are actually studies now showing that men who are on Viagra chronically have lower rates of Alzheimer's,
Yeah,
probably because of the nitric oxide.
yeah, it makes sense. It does the same thing as nitric oxide, so you get more blood flow to the brain, not only to your other body part, but also to the brain.
Exactly.
Yeah. Okay, Josh, this has been enjoyable, and
Likewise, Dr. Mark. Yeah.
thanks for taking the time.
Awesome. All right. We'll see you soon.
Yep.
Feel better.
Yep. Bye.